All right, so as I said before, CAD, if it continues to happen and if we don't do anything about it, it can lead to coronary ischemia. And if that gets prolonged, it can cause cell damage and cell death, leading to myocardial infarction. So, what happens in myocardial infarction? So, what does that mean? So, the definition of myocardial infarction is sustained coronary ischemia leading to irreversible cell death. So this is when you can't really change the damage anymore and the damage is done, right? Once the cell is dead, we can't really regenerate it. In ischemia, you can still reverse it. Now in infarction, that's it. Anyhow, signs and symptoms of MI or myocardial infarction include intractable chest pain. So I'm going back. Signs and symptoms mean cues when we're using your NCSBN clinical judgment model. Anyhow, so signs and symptoms or cues for MI include intractable chest pain. So what do we mean by intractable? Meaning it's not relieved by your typical medications or treatments or even resting. So intractable chest pain is unrelieved by rest, oxygen, morphine, nitrates, etc. So let's say we gave our Mona to the patient, it still continues and it's not being effective. We need to start thinking, is the patient having an MI or a heart attack? Now, the description and location varies depending on the patient, and so they may complain of jaw pain, again, just like what I told you earlier, chest pain, back pain, arm pain, depending on the patient. Now, typically, older people, especially women or diabetics, they have some atypical symptoms, so symptoms that are not your typical chest pain, right? Sometimes they may just say that their face is tingling, their jaw is hurting, so it's not your typical site of pain or even description of pain. Some patients will describe their pain as if there's an elephant sitting on their chest, or there's this pressure or sense of impending doom. Anyhow, so what are our assessment findings? So if a patient is having an MI, these are the things that we may find when we're examining our patients. So there are going to be possible changes in their patient's vital signs. The heart sounds may change, their heart rhythm may also change, and then occasionally, depends on the patient, it may change their lung sounds. So they may have pulmonary crackles. They may complain of difficulty breathing or dyspnea. Some will complain of fatigue, diaphoresis or sweating, and then nausea or vomiting. So nausea and vomiting can also be a symptom of MI. Now, labs that we draw or analyze are your cardiac enzymes. So cardiac enzyme examples would be your CKMB as well as your troponins. And you'll learn this some more once you probably go over it in your med surg or maybe down the road, maybe in second or third semester. Now, complications. So these are some of the possible complications from MI. So there could be multiple other complications, but these are the complications that you need to know for this course. So MI can lead to dysrhythmias or abnormal heart rhythms, pericarditis or inflammation of the pericardial sac of the heart, and you can also have heart failure from MI. And some patients, they may develop cardiogenic shock. This is when the heart completely shuts down and is unable to pump without some assistance, or sometimes it just completely shuts off, right? Anyhow, so what are our general treatments for MI? So we give them oxygen, even though, as we said, it may not even relieve it, and make sure that we're controlling our electrolytes, especially our potassium and magnesium, because patients with myocardial infarction are at a higher risk for developing dysrhythmias. And if you have that risk factor already and then you have some electrolyte imbalance, your risk is going to be higher. So if we control our potassium, we keep it within normal, as well as our magnesium, it just keeps our risk for developing dysrhythmias a little lower than if we don't have those under control. Now again, if they already have some dysrhythmias, we need to control those. So if their heart rate is too fast, we need to slow it down. If their heart rate is too slow, we need to speed it up a little bit. So it needs to find that balance to make sure that we're giving enough perfusion or blood flow to the heart and the rest of the body, of course. Now, patient education, it needs to be timed. We need to talk about the disease process, make sure that they receive treatment right away. Again, Time is very essential for this patient. They need to get to the nearest ER. They don't even have to drive. They need to call 911 to get the faster treatment, and also talk to them about the treatment, psychosocial support. And again, it is expected that they'll have a lot of fear, and make sure we follow up on them and what are the things that they need to do once they're discharged from the hospital. So ensuring also that they follow up with their cardiologist, the specialist that they has seen them in the hospital, as well as their primary care provider. All right, so pharmacological treatments for MI or myocardial infarction. So again, we can continue to give morphine for pain management, as well as vasodilators. So the therapeutic class is vasodilator, and pharmacologic class is nitrates. So we have again short-acting nitrates, so nitroglycerin sublingual. You have long-acting, which is your isosorbide mononitrate. You have the topical version, you have nitroglycerin transderm patch, and then you also have the ointment, which is the nitroglycerin ointment. And occasionally some patients need to be on continuous IV infusion of nitroglycerin. Now, we also give platelet aggregation inhibitors or antiplatelet agents. So examples of this are your aspirin and clopidogrel. Now, beta blockers are also given for these patients because beta blockers, as we learned previously, it decreases the myocardial oxygen demand, it decreases the heart rate, blood pressure, and contractility, therefore improving the patient outcomes. And so examples of this include atenolol, your lols, right, metoprolol, and propanolol. Now, we also give calcium channel blockers to these patients, and this helps with decreasing myocardial oxygen demand, decreasing heart rate, blood pressure, and contractility, and causing smooth muscle relaxation. So, and that will help perfuse the heart better. An example of these medications include your Norvasc or amlodipine and cardizem or diltiazem.